we're talking about pneumothorax in lamb this morning because it's actually really common for women with lamb to have a pneumothorax or collapsed lung. And probably about 2/3 of women with lamb will have a pneumothorax at some point in their illness. In health, the lung keeps expanded because there's a potential vacuum between the lung and the chest wall. And if air from inside the lung gets into this potential vacuum, the vacuum diminishes and the lung falls away from the chest wall and the lung collapses. And in lamb, this is thought to happen when air leaks out of the lung cysts that are the sort of hallmark of the disease. And for this reason, it's probably more common to have pneumothorax when you've got lots of cysts or when the cysts are a bit larger. What we don't really know is whether pneumothorax is just a random event where a cyst just leaks or whether it's actually associated with the disease being more active. I think in some cases it may be when the disease is more active, but for many people it's just a random, perhaps bit of bad luck. But Maninder will probably talk a little bit about the causes of that later. So this is a chest X-ray of someone with a pneumothorax. Most people realise they might have had one when they have an increase in breathlessness suddenly, and it's painful for them to breathe. And they end up in an A&E department having a chest X-ray, which, if you get those symptoms that don't go away, is the thing to do, of course. On the right of the X-ray is the left lung, that's the heart in the middle. On the right side, the whole hemithorax, the right side of the chest is darker, and that's because there are no lung markings, and the lung has collapsed down and it's formed to make this little thing here. So the lung there is completely collapsed down. So most pneumothorax, if you haven't had surgery before and it's a fairly straightforward one, you can just see on an ordinary X-ray. Sometimes they get missed if they're very small and they're just at the top, but most of the time you can see it easily on a chest X-ray. This is a CT scan of someone with lamb. So this is cross-sectional now. So a cut through the chest looked at end on. This is the back. This is the front of the person. This is the heart area here. And I hope you can see that actually in this case both lungs have sort of just fallen away from the chest wall as air's got into the pleural space on both sides. And if you can see from where you're sitting the lung cysts, some of them are dotted around the edges of the lung, and you can see how they might have leaked air out a little bit, allowing the lung to collapse down. So actually this bilateral pneumothorax, or both lungs collapsing at the same time, is pretty unusual. But does happen more commonly in women with lamb, and so that's often a sign that someone has lamb. And in fact, pneumothorax generally in certain situations is often the sort of thing that makes the penny drop that the person might have lamb. And in young women who don't smoke, because pneumothorax is more common in smokers, it's more common in men. So if you see a female non-smoker without a known lung disease that has a pneumothorax, then often you might think that might be due to lamb. If the pneumothorax keeps coming back, or one lung collapses and then a few years the other side goes, those sorts of things are suggestive that there might be an underlying problem. If pneumothoraxes are hard to fix, that might be lamb. Pneumothorax in pregnancies, and we might talk about this a little bit later, is a common occurrence in lamb. If people have been a bit breathless in the past for no very obvious reason, then they have a pneumothorax, you might think, well, perhaps this is lamb. And if there's a history of angiomyolipoma, this benign kidney tumour that about half of women with lamb get, and then if someone's had one of those and then they have a pneumothorax, the penny really should drop that they might have lamb. And for people who have tuberous sclerosis, which is a genetic disease which has a very high prevalence of lamb, if somebody with tuberous sclerosis has a pneumothorax, then it's very likely to be due to lamb. So if you read the old books, really they say that most women with lamb present with pneumothorax or breathlessness. And certainly when I started working on lamb a while ago now, about half of people presented with pneumothorax and the other half presented with breathlessness. So of the 200 and odd people that we've seen in the Lamb Centre in Nottingham, if you look at what their first symptom of lamb was, breathlessness, pneumothorax, other respiratory things, or the kidney tumours, or maybe no symptoms just found by accident, just under a quarter of them will have pneumothorax as their first symptom. It turns out that it's not quite as simple as it's just a sort of random event. And so this graph shows the frequency in percentage terms of the presenting symptom of people presenting with LAM at different ages. And now in the old days you wouldn't have had an over 50s category at all, but actually this is quite a common situation now. The dyspnea or the breathlessness is in black. Pneumothorax is in red across here, and what you see is pneumothorax is pretty common presenting symptom early on, but actually I've never seen somebody over 50 presenting with pneumothorax ever, which is quite unusual. Most of these people present with breathlessness, and I think in the old days, before we CT scanned everybody, we wouldn't have twigged they had LAM at all, actually. If you look at all the features present in these different patients, so not what was the presenting one, but what's ever happened. Do they have tuberous sclerosis? Do they have the angiomyolipoma? Is their lymphatic system obviously involved? Or have they ever had pneumothorax? Again, pneumothorax and angiomyolipoma are really common in the younger patients. In the older patients with LAM, actually pneumothorax really rare, about 5% ever, but about 60% ever in the younger patients. So if you're older and you're probably a bit less likely to have pneumothorax. This next slide's a bit of a sort of odd thing. This is what we did was we looked at the features of our patient's disease, because women with LAM are not all the same, as you can tell just by looking around the room. Some will have the angiomyolipoma, about half will, but about half won't. In our practice, about 15 to 20% of them have tuberous sclerosis, and most people don't. They have sporadic LAM. Some people have pneumothorax, and a small number of people have obvious lymphatic disease that you can see on scans or x-rays. And if you the thickness of, so the bigger the blob, the more common it is, and the thicker the line joining the things, the more likely the two are to be associated. And so the common pattern really is to have sporadic LAM, to have an angiomyolipoma, and to get pneumothorax. If you've got tuberous sclerosis, you're very likely to have angiomyolipoma, probably a bit less likely to have pneumothorax, but that sort of triad's still there. You're much less likely to have pneumothorax if you've got lymphatic disease. You can see that there's really quite a small line there. So people that get pneumothorax tend to be a bit younger, tend to have angiomyolipoma as well. The people who present with LAM when they're older or who have lymphatic disease are probably less likely to get pneumothorax. It's not an absolute rule, but that's the sort of pattern that's emerging. The other group of people that get pneumothorax frequently are women with LAM when they're pregnant. And this is some really old data now from a reasonably small study, but it seems to be holding true. So this is the frequency of pneumothorax in patient years for women with LAM who aren't pregnant compared with women with LAM when they are pregnant. And so what this sort of adds up to is that on average, everyone with LAM would have a pneumothorax every 6 or 7 years. Obviously, it doesn't work like that, but if you even it out, that's sort of what that figure means. During pregnancy, it's probably every 8 or 9 months, which means sort of one a pregnancy, really, doesn't it? And what you also see is that the need to have an operation for pneumothorax that doesn't settle down is probably 10 times as high when you're pregnant compared with when you're not pregnant. And this is one of the things that we do discuss with people thinking about pregnancy for LAM. So pneumothorax is an important issue for these people. The pneumothorax with LAM is more difficult to treat. If you don't have an underlying lung disease, if you're one of these people that is just prone to pneumothorax, for various reasons, usually tall, thin, younger men. It's more common in smokers. They tend to settle down more easily normally. For some women with LAM, pneumothorax doesn't settle down very well, and about 2/3 of them, if you treat them medically, recur. So this, again, this is sort of old data, but what it means is if you take 47 women who've had a pneumothorax, and I just saw what treatment they got. So most of the time, if you have your first pneumothorax, you'll see a medical doctor who will do an aspiration, just take the air out of the chest, or maybe put a chest drain in, and when the air leak's sealed up, the chest drain comes out, you go home. So if you get that type of treatment, about 2/3 of those recur. And then on the second time, if they do that again, about 2/3 recur, and that keeps happening. And so the pneumothorax tends to recur if you do medical sorts of treatments. If you do a more definitive treatment, and Mr Kalkat's going to talk about those surgical treatments, if you treat them surgically, the recurrence rate is actually much lower. And these figures are probably more biased in favour of medicals. Actually, it's the surgical treatment ones that were probably the more difficult cases anyway. So the surgical treatment's much more likely to be effective than medical treatment, which was really why we've asked Mr Kalkat to come and speak to us today. And this really is translated into guidelines. So these are the European respiratory guidelines, which we wrote quite a while ago now. They're published in 2010, but the American guideline update, which is about to be published, has fairly similar recommendations in it. But what it really says is that you should manage these patients jointly between a physician and importantly, a thoracic surgeon who can actually do the definitive treatment for this. You would not want me doing an operation on you. And the other issue that is important for post-surgery really is there's always been this concern about whether having definitive treatment for pneumothorax makes lung transplant more difficult. The question is, if you stick the lung to the chest wall, if you need to replace it when you do a transplant, actually, can you get it out easily? And actually, it is harder to do. But it's not an absolute no-no. So really, the recommendations we usually think are, if somebody's having lots of pneumothorax, you just need to do what you need to do to fix it properly. So when I see a patient with pneumothorax, really, nowadays, I just phone someone up. Unfortunately, Maninder doesn't work in our hospital, so I phone our local guys up who are also fine. But anyway, now I'm very happy that Mr Kalkat's come to speak to us today, so I'd like to hand over to Maninder now, if that's okay.
Thank you, Simon, for inviting me. And I must say, sitting here for the last about an hour or so, I've really been inspired. And thank you, you have covered most of the stuff which I was about to say, but so yeah, I'll reinforce it, and I'll probably leave it to you to ask me questions and any queries you have. As a surgeons, we deal with pneumothorax, and pneumothorax is that lung has collapsed, and pneumo means air in the pleural cavity. So normally the air should be in the lungs, not outside the lungs. It should stay within the lungs. So once it comes out of the lungs, that's what we call air in the pleural cavity, or collapsed lung, or pneumothorax. And as the air comes out, the lung collapses, because the lung has that natural tendency to recoil, to come back to the middle. So when you breathe, the lung expands like a balloon, and whenever there is any breach anywhere, either in the chest wall or within the lung, then that negative pressure, the vacuum which Simon was alluding to, disappears and the lung will collapse. So that's what it is. And as a surgeon, we deal with this problem day in and day out. What we always dread is LAM. So anybody with a LAM comes in, we always look at other Ruta who's on call. But LAM is not the difficult pneumothorax we deal with, okay? There are other pneumothoraces which are equally difficult to manage, and the commonest one we deal almost on daily basis, emphysema. The patients who've been smoking, they have lungs which are again full of holes and cystic spaces, and they are more prone to rupture and cause pneumothorax, and they are equally difficult to manage. And those patients are actually older, and I'm not being ageist, but what happens is a young girl sitting in front of you, the whole life there, they want to get well and get out, and we get very desperate when we cannot manage that. We just feel very sort of helpless that we have done a job and the lung has collapsed again. So compared to a patient who is 60, 70 years old, who knows he has got a bad lung and who is prepared to be patient and get sorted. So there's a little bit of a problem with us when we are trying to deal with two different groups of patients. And supposedly, these LAM patients, as Simon said, it is in about half of them, it is the first presentation that pneumothorax occurs, and they were otherwise pretty healthy, no problems at all. So that's sort of a categorization that there is a group, primary pneumothorax, where there's no disease at all, underlying disease, and people get pneumothorax. And again, that's a young group, very easy to manage. They come to us. First time, we don't do anything, but second time, we need to do something about it because the recurrence rate goes up. And then this is the secondary group, which I was just talking to you, and then this is another one where basically it is trauma, or we as a surgeons or some interventional people cause trauma from the outside and pneumothorax happens. But the secondary, the LAM sits here, the secondary spontaneous pneumothorax. Normally this lung has a tendency to collapse, but it remains expanded because of this negative intrapleural pressure. Okay, so that negative pressure, it keeps it expanding. And so it's a very simple sort of a logic that if there is any breach in the lung or there is a breach in the chest wall, that negative pressure will be lost. And once that gets lost, this will collapse. And when that collapses, people can get two problems. The one which is very, very clear is that they will get short of breath. But at times, if that collapse is not too big, because what happens is when there is a bit of a leak, the lung starts collapsing, the pressure goes up, the air leak may stop. So there may be a little bit of pneumothorax, but the lung still remains about 70-80% expanded. So you may not get any symptoms. And people who are healthy, the primary ones, may not get any symptom of shortness of breath. But if you have diseased lungs, or if the collapse is more, then you will get short of breath. And that's why the emphysema people do not tolerate any pneumothorax. And same is the situation with the LAM people. Somebody who has got advanced LAM will get more short of breath than the one who are in early stage. And similarly, how bad or how severe the pneumothorax is. The other symptoms which happens is the pain. And that's again pretty common, that as the pneumothorax develops, as the lung sort of collapses, people get pain. It is a pleuritic chest pain because the pleura starts rubbing and that causes pain. So the pain is another common problem, and I'm just saying that because small amount pneumothoraces may not cause any shortness of breath, but they may cause pain. Okay, and so if you ask the question to the people who come with the pneumothorax, they will recall, well, yes, they were having some pain at some stage, but more so once we have done some procedure, the patients come back to us and tell us, oh, well, I got a bit of a twinge of pain the other day when I was walking, going uphill or running, but I didn't get shortness of breath. And you repeat an X-ray, you don't find any pneumothorax, but they may be right. There might be a little bit of pneumothorax happening here and there and causing some pleural reaction, and the pain can happen. So the pain and shortness of breath are the common ones, but there are other reasons. There are other symptoms which are not very common. I won't scare you with those. So that's what I was trying to tell you, that there can be a rent in the lung, and hence the lung collapses. Or it could be in the chest, in the chest wall. So as I said, presentation predominantly shortness of breath or chest pain, but then again there are some others. Now, there is slightly increased risk with pneumothorax as such, if you are prone to it and you fly. Again, with the modern aircraft, this should not happen, but there is a slightly increased incidence of pneumothoraces in the people who are prone to develop pneumothorax, and the LAM includes that group. But that should not stop people from flying. Okay, all you should is, it's very individualized sort of assessment depending on how many incidents of pneumothoraces you had, how bad is the lung, how big the cystic spaces are, how many are there, how many are close to the surface and can rupture. So that sort of things are what we are taken into consideration. But by and large, I don't think the LAM will preclude you from going on a holiday or flying. But deep sea diving is something which can be problematic. Okay? And the reason I'm saying is that I have a patient, not a LAM, but otherwise, who is very passionate about diving, and I always tell her not to do it, but she insists and she always turns to it. So the deep sea diving, I think, is something no. But also, somebody asked, the high altitude climbing, again, puts you at slightly higher risk. And I look at it in such a way, flying is okay. You're flying, you get a pneumothorax, there will be people in the plane who can help you, but you are at a high altitude or somewhere down there and you get a pneumothorax, you may be alone. So avoid that. In LAM or in anybody who has got underlying lung disease, it may not resolve spontaneously. And as Simon said, in these patients, we normally are a little bit more aggressive. But this group of patients and the patients who have underlying diseased lungs do not resolve spontaneously. So we are a little bit more aggressive rather than observing or letting the patient go home. If we have to observe, we'll observe them in the hospital, or we will probably put a chest drain rather than putting needles in and trying to aspirate, because we know they don't resolve that easily. And the complication rates are higher in these patients because of the type of lung it is. So again, trying to show you two x-rays. In this one, you may struggle to see where the pneumothorax is. I mean, you can still see that there is a little bit black area here as compared to grayish, whitish area here, and that's where the collapsed lung is. But then I put that picture in where it's much more clear. As you see, you can see the margin of the lung, okay? And the reason you can see the margin of this lung is because this lung has been collapsed for a while, okay? So as the lung collapses, the periphery of the lung or the pleural starts getting a bit thicker, and you can see that sort of picture. And then you can see that big chest drain there as well, which we have inserted to sort it out. And that's a CT scan. And the CT scan gives you a two-dimensional picture, cuts your body like that from top to bottom, and that is somewhere in the middle here, and you can see right lung, and that is the left lung, and you can see there is a huge black area there, and that is the collapsed lung. Now, while I'm there, just to tell you how does the chest drain works, how does chest drain helps to get rid of that air. So the chest drain is that this tube goes in, and the air should come out, okay? But at the same time, you don't want the air to go back in. So you just cannot put a tube and leave it out in the air, because that negative pressure will suck more air in and the lung will collapse completely. So you have to have some sort of valve there which let the air comes out but doesn't let it go back in, okay? So that sort of valve could be, commonest one is a water seal, or it could be various new valves or machines, which I'll probably discuss later on. So the idea is that you put a tube in with a valve and then let the air escape. And how is that air going to escape? The air will escape if you inflate that lung. And how will you inflate that lung? You'll inflate that lung by taking a deep breath, okay? That is one way. That's the easiest way. That's all we do. You take a deep breath in, and it's just blowing into a balloon, and this will expand. And as it expands, the air will come out. And as the air keeps coming out, one-way valve, the lung will keep expanding, provided it's not leaking any more air. If it is leaking more air, then what will happen is the air will keep coming out. Well, the aim basically is you still keep doing that. Let the air keep coming out, okay? You still keep taking deep breaths, and that's what I tell my patients. You need to do that. As you take more deep breaths, as the lung expands, the leakage is from the surface. The cysts are everywhere in the lung, deep within the lung, but It is the surface cyst which has probably ruptured and is leaking. So what will happen is, as this keeps expanding, the lung expands and comes and touches the chest wall, then nature will heal that. So as the tissue and tissue come together, oppose each other, that leaking air will get sealed. Okay, so that is just sorting the way we seal the puncture of the tube of the tire, that you put a sticky thing on it, and here the sticky thing is basically the chest wall. So as it comes and touches the chest wall, and the one-way valve keeps working, you do keep doing all the bits we have asked you to do to make sure the lung keeps expanded, it will heal, it will seal that leak. In addition to that, what we can do is we can put some suction on the tube. Okay, so we can apply a suction so that the pressure, that negative pressure, is further augmented. So with your effort to push the lung out, and with the negative pressure, the lung will probably expand and touch the chest wall, and hopefully it will sort the problem out. Okay, so the treatment, as I said, we can observe. If there's very small pneumothorax, patient is symptomatic, you can observe. But normally I would like them to be observed in the hospital, not letting them go home. Or we can aspirate. Again, as I said, in a normal lung it works, but in patients with a diseased lung and LAM, it may or may not work. But this works. Okay, the chest drain will work. The chest drain, as I said, it works, and I've explained how it works. There are certain other adjuncts which will help to stop the air leak. So once the lung comes and touches the chest wall, that raw surfaces, the nature is trying to seal it. So you get an injury, for example, what happens? You don't put a stitches. It comes and it seals itself. That's exactly what happens within the chest, okay? So once it comes, it should seal. But if it doesn't seal, let us say, then you can apply certain other material, some glue or some stuff, to make it seal. So what can you do? You can do a few things. And all those few things work on one principle, that you cause inflammation. Okay? You cause the injury. So if you cause the injury, the nature will seal it a little firmer. Okay? So the inflammation, the injury acts like a glue. So you are creating an injury by spraying some talc powder on the surface of the lung and the surface inside of the chest wall. That causes inflammation, and the inflammation will heal. And as it heals, it will heal that leaking spot. You can also put some blood. So again, what blood does is that it is sort of a proteins and stuff, and again a little bit of inflammation. So they all work together to again sort of seal it. And I'll come to that in a minute. So these two adjuncts, either doing a talc pleurodesis or doing a blood patch, can be done non-surgically. So you have put a drain in, you can put some talc powder through the drain, or you can put some blood through the drain. Now, for all these to work, here, the most important thing is one. And that most important thing is that the lung should touch the chest wall. Because if it is not expanding and if it is not touching the chest wall, none of them is going to work. Okay? And that may happen if the air leak is far in excess, that there's so much of air leak that the drain cannot cope and it keeps leaking, or the lung has been collapsed for a period of time and it is refusing to come up. Okay? This normally doesn't happen in patients with LAM because they are relatively young, they became symptomatic easily, so they come to us early, the lung has got a compliance, it will expand. But at times, it may not. And in that case, this will not work. So the most important things for these to work is that the lung should expand and touch the chest wall. So if that doesn't work, then we have other options. And also, as Simon said, they may work, but it may reoccur. Okay? So 2/3 of the patients with LAM will have a pneumothorax. With this treatment options, which I've just said, again, about half to 2/3 will reoccur. Okay, and when they reoccur, we want something much stronger than that. Or if the air leak is continuing, we may have to do something. Okay, and that's a big problem. That if there is an air leak, what to do with it, and I'll just come to that in a minute. And then I'm going to discuss with you surgery. I just want to show you what the chest drain, the mechanism is, and the things have improved. This picture I've purposely put in here. This is a water seal, and this used to be the commonest valve mechanism we use, and we still probably is the commonest one, that you put a tube in and then you dip it in the water, okay, and this, as you take a deep breath in, the water column will move by a few centimeters, so the air will not go back, but the air will keep coming out. But the important thing here was that you had to carry it like this below the lungs, because if you lift it up here, and as you take a deep breath in, the 5-6 centimeters will push the water in. And then there will be no water and more pneumothorax, and some water is also going to your chest. So this was a bit of an issue that you had to carry it all the time, like this. Also, if you apply a negative pressure, then you basically get a bed bound. You connect it to the wall and you have to be there. So this has improved in the sense that now we have continuous suction machines. So they are lighter. You don't have to attach it to any wall. They are charged, and you can be mobile and move around. So this has made life slightly easier for us to manage patients with the pneumothoraces, which are difficult to manage. Now, what is surgery? So what surgical options we have, and where does my role come in? So I've got two roles here. One is to make a diagnosis. Okay? Now, Simon can correct me if I'm wrong. I think with HRCT, and HRCT is a very high resolution CT scans, you can confidently make a diagnosis. And I wish the physicians tell me it is a LAM, we know it is LAM, that's it. And if that is the case, I will not like to cut into the lung. I will not like to take a biopsy, and I'll tell you why when I show you a picture. So if I'm certain that this is a LAM, I do not want to touch the lung. Okay, then my role is simply to make the lung expand, to get rid of the air in the pleural cavity, and for that matter, all I'm doing is what has already been done, but I'm doing it a little bit more aggressively then. So what we do is, and majority of times we do it with a keyhole. We make 1 or 2 holes in the chest. We put a camera in, and then we do either what we call pleural abrasion. And what pleural abrasion basically is this, that you take a sandpaper, or, well, medical sandpaper, or a swab or something, and you rub the inside of the chest wall. And rub it real aggressively that it actually starts bleeding. So there is a layer called pleura which covers. This is a very, very flimsy layer. So basically you take that layer off, you rub it off. And so what this causes intense inflammation. Very, very intense. Okay, there's a blood there, there's a lot of raw surface. And so what will happen is that as the lung expands now, and you attach a suction to the drain, it will form adhesions. So there will be air leaking, but with the continuous suction, with the lung coming and touching that raw area, there's a very, very high chance that the seal will happen, that it will stop leaking air. Okay, and this happens, fortunately, in majority of times. Okay, or what you can do is you can go a step further. You say, well, let us take the pleura off completely. And that's what's happening here. So this is a pleurectomy. So you basically lift the pleura off the chest wall. So to take that flimsy layer right from top to bottom, and that's quite a big layer, you just rip it off. And again, idea is the same. It is pretty destructive procedure to do, but it works. Okay? And for that matter, it hurts as well. Okay, but the idea basically is that you cause intense inflammation, intense injury, and let the lung get stuck to the chest wall. Okay? And once that happens, once the lung is stuck to the chest wall, the air leak will stop. So the idea is to leave it stuck. And just to let you know why I don't want to cut the lung into the lung. Now this is a commonest cause of pneumothorax, the primary one, okay? So if you see, this is a lung, this is my stapler, and you can see this bulla. So this is a ballooned out, small ballooned out part of a lung. The rest of the lung is absolutely nice, clean lung, just the tip, right at the top. There is a part of the lung which became weak for some reason, and it is just like a grape, at the top, and that's what's leaking. So for me, what I need to do is I just need to take that bit off, and I'm cutting into and repairing a lung which is a healthy lung. So it will work. Now what happens in the LAM is this. So this is a picture, this is a CT scan of a LAM, and you can see a lot of tiny holes everywhere, okay? And that's what they look like inside. But these are the cysts, tiny cysts everywhere, yeah? So these are the cysts present everywhere in the lung. So this is a little bit more aggressive form. The cysts are actually much bigger here. Now, this is the reason I don't want to cut into this lung. Because if I try to cut it into this lung to take a biopsy, for example, my suture line or my staples are going through it, and as they're going, they may go through this as well, and this is a thin, very, very thin, papery thin area. So my sutures or my staples will just cut through it. And imagine when you are coughing or you're sneezing, you are creating awful lot of pressure, okay? That will leak, okay? So that is the reason this is a difficult problem to sort out. So these cysts can leak. So if there's a propensity for them to leak, any of them can leak from the surface, okay? And if I'm trying to do anything to this lung, I will compound it further. There's a very high chance that my suture line may leak. So if we can get a diagnosis without this, I'll be happy. But if not, then I will just lift as was done in the last case. We lift that bit up and we just take a small sliver of this out and send it for examination. And that's what happens. You do the procedure, you do everything, you put a drain in, and then that can happen. The lung still collapses, or the drain doesn't stop leaking air. And that's when the situation becomes desperate for the patient and for us as well. So normal circumstances, this procedure, as I said, it sounds a little horrible to do, but it is a very simple, straightforward procedure. Patient goes home in 24 to 48 hours with the drain out. But this one can carry on and on and on. So you do the procedure, air is leaking, you cannot take the drains out. Till air leak stops, the drain cannot be removed. Because if you remove the drain, the pneumothorax will reform. So you have to be patient. So that is the name of the game here, patience, okay? So you need to leave the drain in. Yeah, air leak is there, just persevere. Because at the end of the day, the lung is not too bad as such. Between the cysts, the rest of the lung is good. Okay, it is one of those cysts which is leaking. So the hope is that ultimately the adhesions will form. And if they don't form, you can put some more talcum, put a little bit more blood in, keep it on suction, keep doing physiotherapy, keep the lung expanded, and hopefully it will stop. But yes, there are occasional cases where it may not stop, but if it doesn't stop, then the chest drain will stay in. The time scale, we don't know, but till the air leak stops, the drain will not come out. That may mean weeks or even months. The air leak has to stop. And I'll come to that in a minute. The question which somebody will ask, what if it doesn't stop? Or if the drain was removed and that thing has happened, the lung has gone down. Okay? So ideally, we will not like to remove the drain out till the air leak stops. Okay? But that doesn't mean you cannot go home. You can go home. We can attach a flutter bag, or we can attach what we call various sort of valves, or we can even give you that machine which keeps it on a continuous suction. But the drain has to stay in. It does hurt. It is a nuisance. But I think it is important. And why is it important? Why do we want the air leak to stop? Why do we want the lung to expand? It's one simple reason. The simple reason is that a collapsed lung like this or that leaves a space. Any empty space in the body is bound to get infected. Okay, and that's a problem. Okay? The problem is, of course, the lung collapsed and you're getting short of breath, but the biggest problem for me is that if I leave that space for a long time, it will get infected. Okay, for that matter, it is important that the air leak should stop, and then the lung expanded, touching the chest wall, repeat the x-rays and everything, and if it's okay, then remove the drain. So, as I said, it is a problem. We have to be patient. We have to persevere. And in majority of cases, it works. Okay, lung comes up, and ultimately you're able to discharge the patient. But there will be few who will come back. They'll come back within few weeks. They may come back within 6 months with the pneumothorax again. Now, two things can happen. Either the pneumothorax is very small, so the adhesions had formed, so it's all glued everywhere, except in that area there is a cyst which leaked. So there was an air which leaked, but because rest of the lung was so badly stuck, there was a bit of pneumothorax just in that area, and that's it. That's fine, no problem. That bit, if the adhesions which are formed are very, very hard, then that's okay, because the bit of air which has leaked will be in a very small contained area that may cause that pain which I mentioned earlier. You will have that pain, but nothing more. So we just observe, and that'll be fine. But in extreme situation, what will happen is that as the air leaked, and the air leak is so intense that it actually rips off all the adhesions which were formed, and the lung collapses again. And then you are back to square one, basically. So you go through the whole process again, put a chest drain, do a procedure if you want with a VATS, and then see how thing goes. And again, it depends how bad it is, what is the situation, how patient feels. You can straight away go for the surgery. That is what we would like to do. If not, you can probably put a chest drain, put it on suction, and see how things are. In extreme cases, as in this one, and this particular lady, I remember, was very, very, very difficult. The lung will refuse to come up. The lung will continue to leak lots and lots of air, and we struggled. And this was the most extreme thing we did, that we actually did a thoracotomy. We opened the chest completely, and idea was to become even more aggressive, more brutal with inflammation, cause so much inflammation. So cutting the chest open will cause intense inflammation everywhere. The aim is still the same, that you cause the lung to stick, because lung stuck to the chest wall is what will get rid of the leaking point and also get rid of the empty space. So that's as far as managing the pneumothorax is concerned and my role in that. But as I said, very commonly we are asked to do a diagnostic biopsy, but rarely there are certain other conditions which we occasionally see and we can manage them. Okay? So chylous effusions, again, commonly is managed medically with the sirolimus and stuff like that. Very, very rarely a patient will come to us for the management of chylous effusion. Again, treatment still remains the same. You do pleurodesis. If you get rid of the space, there will not be any space for the chyle to collect and it will be sorted. Lymphadenopathy, again, we don't do much about it. We know this, it's there. Very rarely, and we have one patient presented to us in one of the meetings where they developed what we call AV malformations, and patient had a blood coughing out. Again, we can get that sorted. And those are the rare ones. Now, the other role which I have is a lung transplantation. Now, few of the LAM patients will end up in lung transplantation. And what is that number? I think it is very, very small number. Of all the lung transplantations done world over, it's about 1% of those lung transplants which have been done for LAM. So I think, as Simon probably will tell me, that the management of LAM has improved over a period of time, and there are a lot of people who continue for many, many years, 20, 25 years, without getting to a stage that they can't really fend for themselves. But if that situation develops, that you are in what we call NYHA grade 3 or 4, that you are in the bed more than 50% of the time, or worse than that, or what we call the lung function is less than 30% of what it should be, you are less than 65 years of age, and you fit rest of the criteria, lung transplantation is an option. And again, whether you do a single or bilateral, we normally do bilateral ones. We are moving more and more to the bilateral lung transplantation, simply because it doesn't really improve the survival, but it improves the quality of life, it improves the shortness of breath, but also because of that tendency of pneumothorax developing in the lung which has been left behind, that can become an issue. So for that matter, we tend to do bilateral sequential lung transplantations. Other problems, kidney tumors and stuff like that, is not a contraindication. And as Simon said, I think those guidelines are pretty old. Whether you do talc peridosis, whether you do pleurectomy, whether you do pleural abrasion, whatever you do, I think that's not a contraindication. It makes life difficult for us when we are trying to take that lung out. There's more chances of bleeding post-operatively, but they can all be dealt with. That's not a contraindication. So the idea when the patient presents to us for the first time is to get the pneumothorax sorted by whatever means. Few years ago, that was the teaching, that try not to do talc peridosis if possible, because that causes very, very dense adhesions. But that no longer is something I'll be too worried about. There are few reported incidents of recurrent LAM developing in the transplanted lung, but again, that is just what they found. They didn't have to explant that lung.